of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Delphine Ria from Paris, and she's going to lecture us on chronic myeloid leukemia, certain difficult situations in management. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Novartis, Zydus, Unipath, Natco, and Lucian Life Sciences, and very well managed by Perfect Square. I thank Novartis, Zydus, Unipath, Natco, and Lucian, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Cecil Patra from Kolkata, our guest speaker for the day, Dr. Delphine Ria from Paris, and all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, as well as you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 4th of October 2025, we have got two lectures. First lecture is at 5:30 p.m. Indian Standard Time on how do I manage relapse refractory multiple myeloma by Dr. Varun Bafna from Kolhapur. And the second guest speaker is Dr. Rajesh Chakraborty speaking to us on AL amyloidosis from Colombia at 7 p.m. Indian Standard Time and 9:30 a.m. Eastern Time. The following date, it is Sunday, 5th of October 2025 from 11:30 a.m. Indian Standard Time. We have Dr. Nikhil Kumar from Gurugram speaking to us on precision medicine in hematology from genetic insights to targeted therapies. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. And they are very important and eminent hematologists as well as hemato-oncologists all over the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We have no other than Dr. Delphine Ria from Paris. We all know Dr. Delphine Ria very well, but it's my formal duty to introduce Dr. Delphine Ria. She has been our speaker multiple times on this platform. And just to introduce her once again, she's DMU Hematology at St. Louis Hospital, Paris, France, Intergroup of Chronic Myeloid Leukemias. She has been appointed at St. Louis University Hospital, Paris, France, where she works as a physician in the Department of Hematology. Her main clinical and research interest focuses on malignant myeloid disorders. She is responsible for the chronic myeloid leukemia clinical care and research program. She has been the principal investigator as well as investigator of many academic as well as industry-sponsored clinical trials which are dedicated to chronic myeloid leukemia, including pivotal studies that have led to the approval of tyrosine kinase inhibitors and treatment-free remission studies. She belongs to the board of directors of the French cooperative group of CML and contributes to the CML project of the European Leukemia Net, to the Organization Committee of European School of Hematology, ICML-F Annual Conference, to the Society of Hematology Oncology, SOHO Annual Meeting Education Committee, and to the Scientific Advisory Board of ICML-F. Today she's with us and she's going to lecture us on chronic myeloid leukemia, certain difficult situations in management. But before she does that, let me introduce our special guest and chief guest for the day. We have with us Dr. Cecil Patra. Let me introduce Dr. Cecil Patra to all of you. Dr. Cecil Patra is consultant hematologist, hemato-oncologist, and BMT physician at Narayana Super Specialty Hospital, Kolkata. It's my privilege to welcome Dr. Cecil Patra to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Cecil Patra.
Thank you, Doctor, for my introduction. Thank you, Hematology Group, for giving me this opportunity. And thank you, MB Agadol sir, for special thank to Dr. MB Agadol sir for giving me this opportunity. For this topic, I can say good morning to everybody, distinguished colleagues, mentors, and the brilliant minds who will shape tomorrow's medicine. Let me begin with a moment that changed my life. A young patient once asked me, Doctor, will I have long enough to go back to school? That question was not about survival, it was about hope. And that is what hematology gives us, the power to restore futures, rewrite destinies, and reignite dreams. Hematology is not just a specialty, it is the birthplace of revolution. The first successful targeted cancer therapy, imatinib in CML, came from this field. Today, we stand at the frontier of gene therapy, CAR T-cell therapy, and stem cell transplantation, offering cures where once there was only comfort. India faces a growing burden of hematologic diseases. Over 16,000 new cases of multiple myeloma annually. Leukemia incidence rising, especially among younger adults. Thalassemia affects over 100,000 patients with 10,000 new births each year. Hemophilia and sickle cell disease remain underdiagnosed and undertreated in rural regions. Yet, we have fewer than 510 hematologists for a population of 1.4 billion. This is not just a gap, it is a call to action. To the young doctors here today, if you are looking for a career that blends science with soul, choose hematology. If you want to be at the cutting edge of the medicine, choose hematology. If you want to change lives, not just treat symptoms, choose hematology. This field offered you a dynamic path in clinical care, research, and education. Opportunities to work with patients across all age groups, the chance to engage bench to bedside innovation, a role in curing previously incurable diseases, a career that is not just a profession, it is a purpose. Yes, there are challenges. Limited access to diagnostic, high cost, and infrastructure gaps. But these are not barriers, these are the invitations. Invitations for you to lead, to innovate, and to build the hematology ecosystem India desperately needs. So I urge you, step forward, specialize, innovate, and inspire. Be the generation that brings equity, excellence, and empathy to hematology. Let your career be more than a job. Let it be a legacy. Let us build a future where no child asks if they will live long enough to go back to school because they already know they will. Thank you.
Thank you, Dr. Sisil Patra, for the wonderful words of wisdom and kind words. It means a lot to us. And thank you for being as a part
Thank
of
you.
the chief guest for the day today. Thanks a lot.
Thank you. Thank you.
And now, ma'am, the screen is yours. Please go ahead.
Thank you very much. Dear Dr. Kohana, dear Dr. Patra, thank you very much for your kind introduction and very, very wise words. Dear colleagues, I'm very happy to share this session with you again. I will try to share my screen. I'm not a professional of, of sharing screens. Let me see before I start.
Just a full screen mode.
Yes.
Yeah.
I hope then this is a full screen. Just tell me whether you
Yes.
see the full screen or not. Thank you very much.
Yes, ma'am.
So for today's session, I was asked to talk about difficult situations in management in chronic myeloid leukemia. And when I was before preparing my slides, I was wondering what should I talk about. And I started to try to list a certain number of clinical situations in which myself and the patients had a hard time to deal with. At diagnosis, there are sometimes very difficult complications. Some patients coming with hemorrhages, spleen rupture, or things that are really difficult to deal with. There are also sometimes situations in which the diagnosis of CML may not be immediately straightforward. And there are also some situations I still don't know how to deal with today are the very few patients who have very poor prognosis, cytogenetic abnormalities with abnormalities of the chromosome 3, MLL, and TP53 genes. Then during TKI treatment, I isolated a couple of topics also, like deep cytopenia at the beginning of the treatment or late during the treatment. This is very often a source of complications for the patient and difficult to reach optimal responses. There are also few patients who have to face what I call a multiple TKI intolerance syndrome, regardless of the drug that we are using. The poor adherence behavior are also difficult to deal with, and of course the resistance. And as we have now new drugs, we are wondering what to do after we use these new drugs, especially what to do after allosteric inhibitors. Now, there are also other topics like the TFR in non-optimal settings, acceleration blast crisis, pregnancy, when to proceed to allogenic stem cell transplantation, This may look a long list to you, so I was wondering, I was telling myself CML seems to be a very easy disease, and in fact, it's not always the case. So, of course, today I will not cover all of this topic. I will focus on rare cases with unusual presentation, how to deal with cytopenia at the beginning of the treatment, and what does it mean to have cytopenia long after treatment has started. And I'll tell you a little bit more about the mechanisms of resistance to allosteric inhibitors, since these are new drugs, and what to do in case of new mutations that we were not aware of. So with respect to unusual presentation at diagnosis, I will start with the patient case here. And this is a man. He was quite young at CML diagnosis, 30 years. He didn't have time yet to build a family, but he was an active worker. He had no comorbidities. And for some reasons, he had to borrow some money to the bank to buy his first apartment, and he had a health checkup because of this. And you see that he had normal leukocyte counts. The differentials didn't show any significant abnormal cells, but you see that basophils were too high as compared to the upper normal limit. Hemoglobin was high also, 17.4 grams per deciliter with a hematocrit of 53%. The red cell volume was within the normal range, and he had a mild thrombocytosis, 614,000 per millimeter cube. So when we had to, and he repeated this, of course, and these abnormalities were confirmed, and the first diagnostic investigations didn't tell us much. The physical examination was unremarkable. There was no iron deficiency nor inflammatory syndrome, and he had a spleen. I mean, not a big spleen, normal spleen. So we had to go deep into depth into diagnostic investigations, and we first thought about an MPN disorder, but the red cell mass was normal, as well as EPO dosage, and CAL-R, JAK2, and MPL were unmutated. So we went further and performed a bone marrow aspiration with cytogenetic and more molecular analysis. And as you can see here, the cytology showed normal bone marrow cellularity and myeloid erythroid ratio. But we had the surprise to see that on the cytogenetic, we found the Philadelphia chromosome in 19 metaphases. The arrows are shown here with the 9q plus and the 22q minus, the Philadelphia chromosome. And indeed, the BCR-ABL transcripts were present. Sorry about that. It was major transcripts. So this unusual presentation was chronic phase CML, and the prognostic scores were low. Excuse me about that. The weather in Paris is not so nice. It's about 20 degrees, and it was raining during the whole week. So is isolated thrombocytosis common at diagnosis of CML? No, this is pretty rare. And I would like to show you the studies in which the authors performed a mainland search between 2000 and 2020, and they isolated 20 cases published that could correspond to this. And you see that in this series, there is a slight female predominance. The mean age is 40 years, but patients can be either pediatric CML or senior people, so there is no specific age category. The platelet count also is very wide. You see it can go from 594 to several millions, and the mean is quite high, 1.9 million. So really something that could lead to clinical symptoms, while the white cell counts are usually normal, and the splenomegaly is quite rare. It was here present in only 13% of the patients. The clinical presentation is also something important to know. Patients are asymptomatic in about 40% of the cases, and they had symptoms, but not really specific to CML, more specific to thrombocytosis in 60%, like thrombotic complications, miscarriage in women, headache, bruising, or Raynaud syndrome. And like in the patient I showed you, the bone marrow cytology is normal in about 50% of the cases. So this is really misleading. And these patients all had CML and chronic phase in 95% of the cases. And as it resembles essential thrombocythemia in this series, which covers 20 years, 44% of the patients, in fact, received hydroxyurea alone, and the diagnosis of CML was not made immediately. In 2000, we didn't have all of these molecular tests to check for ET, and in fact, most of these patients were declared refractory to hydroxyurea as thrombocytosis was not controlled. So in our cases, the patient was diagnosed quite early and we didn't miss the diagnosis of CML. So we treated him with dasatinib 100 milligram QD. And as he had a low score, as expected, he had an optimal response very rapidly with a complete cytogenetic response within a year and a deep molecular response very rapidly. Now he has undetectable transcripts for at least 5 years. So he's a TFR candidate. So for these patients was quite lucky, as we didn't diagnose CML at a late stage. But that's not always the case, and I will show you 2 other examples in my own clinic, and they are illustrated in the series that has been published that I showed you before. This second patient is a female, and she was 34 years old and a normal life, 2 kids, active worker, non-smoker, no known comorbidities. And she had symptomatic thrombocytosis. She was complaining of renal syndrome and migraine, and she was treated in another hospital, and the clinician considered that she had JAK2 negative ET, and she was treated with hydroxyurea and aspirin. And at one point, the platelet counts really remained very, very high. So she was referred to our clinic for a second opinion due to major thrombocytosis and so-called refractoriness to hydroxyurea. And indeed, when she came in my clinic, she had almost normal, near to normal leukocyte count, a slight increase, but she had 2% circulating blast and basophilia. But this could correspond also to an MPN disorder. Hemoglobin on hydroxyurea was normal, and you see the high platelet counts over 4 million per millimeter cube, and this is pretty high, and this could lead to more serious complications. So we performed more specialized diagnostic investigation, and in that case also bone marrow cytogenetic and molecular analysis diagnosed CML with pH1 in 100% of the cells, no cytogenetic abnormalities in addition to pH1, major transcripts. So in that case, it was more than 6 to 1 year on hydroxyurea. So it's so-called a late chronic phase, although 18 months is not that much, but still. Please note that when we have these patients already on hydroxyurea, we cannot calculate the prognostic scores at CML diagnosis. Prognostic scores such as ELTS and SOCAL should be calculated before any cytoreductive treatment is started, but you see that the high platelet count is not a good prognostic factor in CML. It's an item which is very important to calculate the scores. So we told her she didn't have ET but CML, and she was treated with second generation TKI upfront. She was lucky enough to get an optimal response and even a deep molecular response. As you can see on this slide, with BCR-able transcripts rapidly falling into the MR4 to MR4.5 level. And please note that the platelet counts normalized very rapidly on TKI, which was not the case on hydroxyurea, as well as the renal syndrome also really disappeared, and as well as a headache. So after 6 years of treatment, she was lucky enough to be a candidate for TFR, and she accepted to stop the treatment, and she's still in a TFR, although we can see that the BCR-able transcripts are detectable, but she's still in MMR, so she's still followed without any treatment. Now, these 2 first cases were had a favorable outcome, but this is not always the case, as I said, because this late diagnosis could lead to what we call late chronic phase. And for those who remember the beginning of the imatinib era, late chronic phase CML treated with imatinib had a lower rate of response than early CML. So this is a bad prognostic factor for response to TKI. And this is what happened to this lady. 48 years old, married, one child, and she had an autoimmune disease. So, and she had mild leukocytosis and thrombocytosis in 2002, and her clinician considered that it was ET. Please remember, in 2002, we didn't have all of these molecular markers for ET diagnosis. And she was considered as having ET, and she received hydroxyurea for 7 years, which is really a lot, together with aspirin. She still had a mild leukocytosis, but they considered it was inflammatory due to the autoimmune disease. So here are the CBC counts prior to CML diagnosis and TKI therapy. You see a little bit of basopilia, 1% blasts, and in that case, she was sensitive to hydroxyurea, so the platelets were normalized, but in fact, it was CML. And this patient was, at that time, in 2009, treated with imatinib first line. And as you can see, she became resistant because she didn't have any cytogenetic response at 3 and 6 months, with still 95% of pH1, a high molecular residual disease, no BCR mutation. And at one point, we found a clonal evolution with trisomy 8 in the pH negative cells, which was a worrying point. We were afraid she would evolve towards myelodysplastic syndrome, but this was not the case. So she had resistance disease, pH negative clonal evolution, fortunately no secondary other myeloid malignancy. We changed the treatment, and fortunately nilotinib was able to rescue this patient. So here I would like to remind you the ICC classification of myeloid disease and the diagnostic criteria for essential thrombocythemia on the left-hand side. And this is very clear that when a patient has thrombocytosis, before making the diagnosis of ET, we must be sure that the patient does not have a BCR-ABL positive CML. So molecular biology is mandatory. So I would like to summarize these very rare cases: isolated thrombocytosis, in fact revealing CML. So in very rare cases, CML presents as isolated thrombocytosis with or without clinical symptoms. Unlike classical CML, the splenomegaly is rare. And this is really misleading. The blood and the bone marrow cytological analysis differ usually from that of classical CML, because usually bone marrow doesn't see increased myeloid lineage. So this is sometimes a very difficult diagnosis to make when we don't go to cytogenetics and molecular analysis. So in a lot of patients, inappropriate diagnosis of MPN may lead to the wrong treatment choice and jeopardize the prognosis, as on long-term hydroxyurea, CML may evolve towards other genetic abnormalities and blast crisis, and if not, to resistant disease to TKI. Please note that thrombocytosis at the onset of CML usually is refractory to hydroxyurea. So even when you have classical CML with high platelet counts, it's not the hydroxyurea which is going to decrease the platelet counts, but more the TKI that you are going to start. So this is a different picture as for ET. So TKIs are the appropriate drugs. Prognostic does not seem to differ from that of classical CML, but we don't have a lot of cases. But this is unconditioned that the diagnosis is made quite rapidly, because we know that late chronic phase CML has a lower chance to respond to TKI than early chronic phase. So molecular analysis for BCR-ABL transcripts is critical and mandatory in the diagnostic workup of acquired primary thrombocytosis. This is for these first challenging situations. Now I'll move to some situation that sometimes we have hard time to deal with, especially at the early stages of TKI treatment. And this is when deep cytopenia are occurring, and especially when these cytopenia are recurrent. Usually we don't really know what to do. We decrease the dose. We don't have access to growth factors in all countries. We don't know, and there is a lower chance to respond. So what should we do? So Cytopenia at the early stage of TKI treatment, they are very common, in fact, especially in patients who have a very high leukemic burden at diagnosis and also in advanced phase disease. In fact, we consider that this is due to the toxicity of the TKI, but this is much more complex than that. And the causes of early cytopenia are, in fact, multifactorial. First of all, it's mainly a therapeutic effect and not a toxic effect. And because TKI mainly suppress the leukemic clone and normal hematopoiesis to a much lesser extent, especially when we have very selective TKI treatment as allosteric inhibitor or new ATP competitive inhibitor in development with a high specificity. So hematotoxic effect of TKI may play a role depending on the drug type, of course, but this is not the main reason why there are some cytopenia very deep. And there is also an effect of the leukemic cells, function and burden effect. We know in vitro analysis that leukemic cells inhibit normal hematopoiesis and promote their own proliferation, and they also at diagnosis modify the bone marrow niche through growth factors such as IL-1, chemokines, TGF-beta or TNF-alpha, impairing normal hematopoiesis. So early myelosuppression may indicate either a reduced reserve or a delayed recovery of pH-negative polyclonal hematopoietic stem cells present at diagnosis rather than a toxic effect on non-leukemic hematopoiesis. So here I would like to illustrate the prevalence of cytopenia by first-line TKI type, early phases during the first year. And you'll see that regardless of the TKI we use all between the TKIs, there are cytopenias with all drugs. This is the NSTND with imatinib 400 milligram and nilotinib 300 milligram BID first line. And there are some differences between the drugs, of course. Much more anemia. I think I made a mistake. This is the other way around. With imatinib, it's 38%. Please apologize for this mistake, and 18% with nilotinib. A little bit more neutropenia and thrombocytopenia also with imatinib than with nilotinib. And usually the cytopenia grade 3-4, those who are clinically relevant, range between 5 to 20% depending on the drug we use. Now, if we go to the decision study comparing imatinib with dasatinib, we see that the picture is more or less the same. All grade cytopenia very frequent, maybe more frequent with dasatinib than with nilotinib, but this is not a head-to-head comparison. And the grade 3-4, whether it's anemia, neutropenia, and thrombocytopenia between 5 and 20%. And the picture seems to be a little bit different from in the before trial, which we have hard time to understand. Because you see that here with imatinib and bosutinib, the cytopenia rate is prevalence is much lower. And since this trial is was published in 2018, unlike the decision and NSTND, which were published in 2010, I wonder whether this is because here growth factors were allowed to be used in the study, which was not the case during the development of dasatinib and nilotinib, and this may change the prevalence of cytopenia as we may use preventive growth factors. Now, last but not least, this is a asciminib study, first line, as for first. This is a very selective inhibitor, but still there are some cytopenia, as you can see, although there is the rate here is quite low, which really means that this is not due just to a toxic effect of TKI, as I said, but to the all characteristics of the bone marrow and the leukemic cells that I told you about before. Still between 1 and 15% of grade 3-4. So cytopenia early after TKI treatment this is the slide I already showed. Evolution of early cytopenia, sorry, I'm making a little bit of mistake. So early cytopenia is always almost limited to the first week of months following TKI initiation, as TKI are able to re-establish normal hematopoiesis in most patients. They may resolve either spontaneously or after interruption or dose reduction of TKI parallel to the reduction of the leukemic burden. But we know that in some difficult patients, severe myelosuppression may persist, indicating either a compromised underlying hematopoiesis or a pathological underlying clonal hematopoiesis. And this represents this deep and recurrent cytopenia represent an adverse prognostic factor of response to TKI. I would like to show you and to illustrate you that cytopenia mainly occurs during the first 3 to 6 months. Here it was 12 months in the ASK4FIRST study. As you can see here, on the top, anemia, neutropenia, and thrombocytopenia, and everything which is in blue are the time to onset, and this is 0 to 3 months. So you can see that here the majority of the cytopenia occur during 3 to 6 months, and the other colors are the cytopenia occurring at late stage, and you see they are much less frequent, and I will show you later on that the significance of late cytopenia is very different from that of early cytopenia. So when we have early cytopenia, how should we manage and monitor the patients? So after TKI initiation, first line or later with a high leukemic burden, CBC weekly until a stable CHR is achieved, full blood counts until full blood counts have been recovered, and once CHR has been achieved, in the absence of grade 3 to 4 cytopenia, you can reduce the monitoring frequency. Depending on the patient, you may be more flexible every 2 to 4 weeks until the 3rd month, then every 3 to 6 months. But if you have grade 3, 4, you have to adapt the monitoring frequency. Some patients may need more frequent CBC counts in order to program either a dose reduction, interruption, use of growth factors, or sometimes transfusion. And this is the management plan of this. So how do we manage the cytopenia? Here it's a table which is very busy, and I wanted to show you what are the dose modification according to the SMPC. Depending on whether it's imatinib, dasatinib, nilotinib, bosutinib, or ponatinib, it's going to be the same, I think, more or less for asciminib. And I was really surprised to see that the threshold that they use for neutrophils is usually 1,000, and even in some trials it's 1,500. And this does not correspond to the infectious risk in clinical practice. We all know that above 500 neutrophils per millimeter cube, especially when monocytes are present, the risk of having a severe bacterial or fungal infection is really low. So why should we interrupt a TKI when the patient has 1,000 neutrophils? I personally don't use the same thresholds as indicated here. I start to decrease or interrupt at 500 or below, but not above, because if you reduce too much or interrupt treatment for too long, then you're going to lose a response to TKI treatment and CML control. I would like to mention that this is a little bit the same for thrombocytopenia. More or less, in all of these studies, they use 50,000 to decrease the dose of TKI or to interrupt, which is pretty okay, I think. But in some trials, they asked the doctors to interrupt when platelets were at 75,000, and this is not corresponding to a dangerous threshold for bleeding in the clinical practice. So I think that we should really adapt the threshold to the real clinical significance and not systematically follow this. So we can use growth factor support when cytopenia are deep or when they are not well tolerated to try to avoid transfusions. And here are the key messages. EPO, GCSF, or TPO agonists may be useful in case of deep and recurrent cytopenia with evidence of low marrow hematopoietic reserve. And there is no evidence currently in the literature or in the clinical practice that growth factor support may reduce responses or increase the risk of progression to blast phase disease. Jorge Cortes, when he was still working at the MD Anderson Cancer Center 20 years ago, published a series of imatinib-treated patients, among which the vast majority were anemic, and anemia is usually a problem with imatinib-treated patients, especially in the elderly. The factors associated with anemia here was late chronic phase, because it was 20 years ago, so they had late chronic phase patients. And also, anemia was dose dependent most of the time. They defined anemia in a very classical way. And of course, when you decide to use EPO, you have to rule out iron deficiency anemia before considering EPO. And they treated the patients when hemoglobin was low with 40,000 units sub-Q per week until hemoglobin increased up to 11 or 13 grams per deciliter. And then then they reduced down to every 2 to 4 weeks, and then they stopped when hemoglobin was stabilized at around 11 to 12. And what they found is that most of the patients, so this is the table 2 on the left, most of the patients had an increase in hemoglobins of at least 2 grams per deciliter, and then could stop EPO. And they showed that anemia was very important, because especially in the elderly patient, this could be an indication that of a decreased overall survival, mainly due for an indirect effect, mainly due to cardiac comorbidities. So it's very important to treat anemia, especially in patients who are old or comorbid. So what about TPO agonists? There are several studies which are listed here, some case reports, some series, and also a clinical study a long time ago, phase 2 single-arm study in CML or myelofibrosis, grade 3 or high thrombocytopenic patients. And there were 15 patients with CML with a median platelet count 44,000 per millimeter cube. You see some patients had very deep thrombocytopenia and bleeding. They treated the patients with eltrombopag in case of grade 3 or high thrombocytopenic patients, 50 milligram QD, and patients could have a dose escalation if there was no response. And what is very interesting is that even at this dose of 50, they had 12 out of 15 complete platelet response. And they could show that before eltrombopag and after eltrombopag, what was the advantage of using eltrombopag? Not only increase platelet counts, avoid bleeding, but also restoring a quite efficient dose in TKI administration, because before eltrombopag, the patients received only half the dose, and this was a more efficient dose after. They could increase the TKI dose. And most of the patients, because they had a better exposure to TKI, could obtain a complete cytogenetic or a partial cytogenetic response. So they increased their response to tyrosine kinase inhibitor treatment. With respect to G-CSF, it's also possible to use G-CSF when we have grade 4 neutropenia. At the early stage of TKI treatment, especially, we know that recurrent neutropenia represents an adverse prognostic factor of outcome. You see here the Hammersmith score, prediction of response after imatinib failure to second-generation TKI. And you see the poor risk patients have on the right, they have a low probability to respond to dasatinib, and then intermediate risk, 50%. And low risk, then they will be good responders. And among these scores, the items in the score, there was deep neutropenia during imatinib. I must say that I use rarely G-CSF, and when I use, I prefer to use pegfilgrastim when it's available, because you could just repeat the injection when the neutrophil counts decrease again below 500 per millimeter cube. And otherwise, if you use daily injections, you don't really know what's the right schedule. So here is a patient who had recurrent severe myelosuppression, and sometimes you don't manage with dose interruption, treatment change, or growth factors, and it might be sometimes an indication for allogeneic SCT, and that happened to this patient, 59 years, active worker, still working, no comorbidities, and when he came, he had a huge spleen. I mean, it was down to the pelvis. He had chronic phase CML, no PH1 classical, and high scores, high SOCAL, high ELTS, so a fair chance to resist to TKI. And we treated him with a second-generation tyrosine kinase inhibitor due to the high-risk score and no comorbidities. And he obtained rapidly a CHR, but he had febrile pancytopenia grade 3-4 at 3 months of treatment. We had really to dose decrease and then interrupt, and to perform blood transfusion, growth factors. And despite all of this, he did not recover. Cytopenia were recurring after growth factor interruptions. And he remained 100% PH1 and 3 and 6 months, no ACA, no BCI bone mutation, empty bone marrow on biopsy. And this only way to go further is to perform an allogeneic stem cell transplantation, which we did for this patient, still alive after 10 years and treatment-free. And this might indicate that there was no normal bone marrow reserve anymore, so we could not recover. Now, late onset cytopenia are quite different causes. And so newly occurring cytopenia beyond the first year of treatment is very uncommon. I'm not talking about anemia, which may be multifactorial. And here you really need to perform further investigation and rule out many differential diagnoses. Could be peripheral cytopenia, could be central cytopenia, CML related, or a second malignancy or another cause. And I would like to show you two of my patients. To illustrate this is a man. He was 73 when he was a doctor. When we diagnosed CML, he had some comorbidities, hypertension, atrial fibrillation, very classical CML for this age, a high risk. Because of comorbidities, we gave him imatinib first line, and he had hard time to respond at the beginning. It was a slow response, as you see. At least from the molecular point of view, with a suboptimal molecular response at 12 months, but still improving later on. So late responder, but we didn't rush to change the treatment because of comorbidities, and we were right. And I didn't really pay attention that from the second year of treatment, he had a neutropenia, but he was feeling very well. Neutropenia was oscillating, it was fluctuating, so I didn't really pay attention. But then more than 1 year after, he had grade 4 febrile neutropenia, monocytopenia, and grade 1 thrombocytopenia. He was in MR4, so it was not supposed to be CML. He really needed to have specialized diagnostic investigation. I had the bone marrow, I added immune phenotype, karyotype, and molecular biology. And here is the diagnosis. Here you see on this cytological picture, you recognize these hairy cells. He had a second malignancy, which was hairy cell leukemia, which is a pretty rare leukemia. The good news is that we know how to treat this leukemia, and we know also that we have a treatment which is good for CML and for hairy cell. So I decided to use pegylated interferon and not the very modern molecular targeted therapy, and adapted, of course, to his age. And little by little, he was in remission with respect to hairy cell, and the molecular response for CML improved down to undetectable BCR-ABL transcripts. And this is a nice story because I stopped the treatment, and now he's in 6th-year in TFR, both for CML and for hairy cell. So that's nice. It's not always as nice as this. This is the case for this patient. She was 70 years old at diagnosis. Now she's 93. And she was treated for imatinib for a very long time. And as you can see, this year I had the bad surprise to see a sudden grade 3 neutropenia and grade 2 thrombocytopenia. And it was sudden, not like for the other patients. So bone marrow, immune phenotype, karyotype, molecular analysis. And unfortunately, this is IDH1 mutated AML, Philadelphia negative, as she is on undetectable BCR-ABL transcripts. She is now on targeted therapy. But at this age, we cannot hope for a cure. So I'll finish, if I have a little bit of time, with resistance to allosteric inhibition, as you will see. So this is a new drug category which is going to expand, I believe, because we know that the side effects are really reduced and the quality of life of the patients are much better. So we know that asciminib is the first, but there are others under development, such as the Tigrex in China and the TERN-701, an international development for this drug, which has the advantage to be used with or without food, and also to be tested at high dose in the clinical study. So we know we have to learn about mechanisms of resistance, and we need to know how to fight these mechanisms of resistance, not to be afraid of treating our patients, and to recognize also the mechanisms. This is a resistance to TKI definition, which has not changed over the years. ELN 2025, the recommendations are now published, and NCCN 2024 and now 2025. You can still see that nothing has changed as compared to previous year. Above 10% of BCR-ABL by 6 months, above 1% at 12 months, or resistant mutations regardless of the time it occurs. So nothing really new with respect to the definition. So Is it frequent, the resistance to asciminib? Here is the illustration during the first-line treatment, because we hear that it's more efficient than imatinib. We hear that it's probably a little bit more efficient than second G, but still it's not a perfect 100% successful drug. We can see that 5% of the patients quit the study due to treatment failure during the first year of treatment. It's not much. It's much less than for the other drugs, but still it's 5%. We can see that 10% of the patients don't have an early molecular response at 3 months, and at 1 year, still 13% above 1%. So, which means roughly between 5 and 10% of patients may have resistance to first-line asciminib. In this study at least. So what are the mechanisms? Now we know a little bit better about resistance to allosteric inhibitors, and this may sometimes be a challenge. That's why I chose to finish my talk with this. And I made an intense literature search together with my own experience. First of all, I realized, because asciminib now is tested in studies in Ph-positive ALL and lymphoid blast crisis, that the P190 BCR-ABL, so E1A2 transcripts, they had a decreased sensitivity to a drug which is called GNF2. What is GNF2? Well, that's the ancestor of asciminib. So we have to be careful about rare transcripts. Some may be not as sensitive to allosteric inhibitor as P210. And ways to overcome resistance might be to use a higher dose than the standard dose. We also learned that rare transcripts with an A3 and not an A2, so they lack exon 2 sequences, they lack SH3, part of the SH3 domain. They are completely primary resistant. Here, allosteric inhibitor, regardless of its asciminib or another one, it cannot work. So if we have these rare patients, we need to use ATP competitive TKI. We also know that some of the allosteric inhibitors are sensitive to a drug efflux pump, and this is the case. Asciminib is very sensitive to this. We can combine asciminib with a BCG2 inhibitor in vitro to revert this mechanism of resistance. And please note that ponatinib is an inhibitor of this efflux pump. So the people who are testing combination therapy in highly resistant disease may revert this efflux pump resistance mechanism. But we have new allosteric inhibitors, which at least in vitro are not a substrate for these pumps. And now the mutations, because these are the ones that we see in the clinic. Single ABL1 mutations, and so this was to illustrate that the rare transcripts were less sensitive to allosteric inhibitors. On the right-hand side, you see this was one of my patients in a phase 1 study. She had a B3 transcript treated with asciminib, with imatinib, and then asciminib-imatinib combination in the trial. But then she stopped imatinib because she didn't tolerate it well, and she relapsed. And she responded to imatinib when we reintroduced the drug, and it was shown that, in fact, this was because these transcripts were not at all sensitive to allosteric inhibitor. And this is the in vitro work published more than 10 years ago to prove that, at least in vitro, P190 is not as sensitive as a major transcript to GNF2. So coming back to the mutations, if we look at the type of mutations that emerge in the asciminib study, and also now we have more experience with a routine practice, you see that there are a lot of mutations which occur in the myristoyl binding pocket so preventing the drug to bind, or at least to bind correctly. And we are not used to see these mutations with ATP competitive inhibitors, so we have to learn what to do. And I want to update the ELN recommendation and also a publication which is in French, so not very helpful for you, but it's a French group of CML plus the French group of molecular biologists in hematology, providing guidelines about what to use depending on the type of mutations that you have. And if you focus on the ELN 2025, you see that we should not use asciminib when there is a P-loop mutation, such as M244V, V299L, T315I, of course you can, but it's a high dose. But here you see down the two last lines, myristoyl binding site mutation and SH2 kinase linker mutation. So in that case, don't use another allosteric inhibitors, but use an ATP binding competitor. And now there are several case reports telling us that dasatinib is very efficient to rescue the patients with such mutations. This is one of my patients, but now I have more. And this is just an illustration, but it's confirmed by others. So here, asciminib first line, A337T, most frequent mutations, myristoyl binding site during asciminib treatment. In routine practice and in the study, you see here it's illustrated in the middle, it's in the myristoyl binding pocket. And these patients are usually very nicely rescued by dasatinib when it's the only factor of resistance. And I think have been a little bit long, so and you might have questions, and I would like to warmly thank you for your kind attention.
Thank you, ma'am. Wonderful lecture, wonderful presentation. Learned a lot. Fantastic, ma'am. And I now request all our discussants to please put the hand raise sign so that we can start our question and answer session with Dr. Delphine Ria, ma'am. So in the meanwhile, there is one question from the chat box. How do you manage patients who have frame shift deletion in BCR-ABL kinase domain mutation who are not achieving milestones on imatinib?
So if they are either in warning situation, but with a mutation, I would be afraid. So usually this is classified as not warning anymore, but resistance. And when it's true resistance also. It is true that we don't have a lot of experience on patients who have frame shift mutations. So the literature is quite poor. I have the tendency to use a second generation TKI, usually dasatinib, with a pretty good rate of response, but I must say that this is based on clinical experience and not so much on the data that have been published. There are some isolated case reports. So I think you should try dasatinib first and then try to figure out whether the patient is going to respond. I must say that there's no data with allosteric inhibitors. So in that way, I would not use allosteric inhibitor until we have more mature data on these patients.
Thank you, ma'am. Another question is from Dr. Kostuk. For patients presenting with isolated thrombocytosis and those who are resistant to hydroxyurea, and before the diagnosis of CML is made and TK is started, do you use options like platelet apheresis to prevent complications which are related to thrombocytosis?
So it's a very important question because usually these patients which don't have ET, they are quite resistant to hydroxyurea. And even in classical CML, which very high platelet counts, you usually see that when you start hydroxyurea before CML diagnosis, leukocytes decrease, but not so much platelets, and the platelets normalize after TKI has been started, but after leukocytosis has been controlled. So it's not the same kinetic. So yeah, you could eventually use, some people use anagrelide, which is not very well tolerated, and also it takes time to act. So in fact, the best way is to start a TKI. This is the only way to decrease rapidly the platelet counts. But in case of emergency, yes, you could lose platelet apheresis. I must say that we must be very careful with aspirin. This is classical in ET, but in CML, there could be acquired von Willebrand disease. So when we are sure that it's CML, I usually avoid aspirin. We had some cases where we had to transfuse platelets from a normal donor, although the platelet counts were high due to life-threatening hemorrhage. And if the patient has a thrombosis, I prefer to use low molecular weight heparin.
Thank you, ma'am. Another question is from Dr. Ali Mahmoode. One of the side effects of hydroxyurea is again thrombocytopenia. Why do you say that hydroxyurea does not contribute to platelet count reduction in CML case?
This is a very good question, but I must say I don't have the answer. But it might be that the clones with BCR-ABL are not as, and I mean, at least the megakaryocytes, they are probably not as sensitive as the one who have the JAK2 or CALR or MPL mutations. I don't think this has been really studied in vitro to look at the differential sensitivity of megakaryocytes to hydroxyurea in CML versus in MPN.
Thank you, ma'am. Dr. Chirag Shah, your question, please.
Yes, good morning, ma'am. excellent discussion. Really, CML, as you said, we thought it was a easy disease, but now we are finding more and more difficult cases. Now, the guidelines say that TFR be restricted to low risk SOCAL score, but there are patients who have, very good responder, high risk SOCAL also, and your patients with 4 million platelet, you also did TFR. So when can we attempt TFR in a patient with high risk or intermediate SOCAL?
Thank you very much for this very important question. Indeed, a lot of patients are either intermediate or high risk. And I would like to point out that probably low-risk patients behave a little bit more or less the same as intermediate. So I think that two categories are probably better than three, like low and intermediate and high. In the NCCN recommendations, there is no selection according to the SOCAL risk group or ELTS with respect to TFR. So the American people, they don't restrict TFR to people with a low risk. And we also did not, at least in the French recommendation, but they have been published a long time ago, we allow high-risk patients to stop. I must say that with respect to prognostic factors, when we are talking about the scores, these are the scores at diagnosis. But when patients then start the treatment, there is a dynamic evolution of the situation. And sometimes the treatment is going to be able to erase the bad prognostic characteristics at diagnosis. Some characteristics at diagnosis will still have a footprint after a couple of years of treatment, but some might be erased by the treatment. And I strongly believe that the patients who have high risk, but who manage to get upfront deep molecular response, there is no evidence that they have a much lower TFR rate anymore as long as they are treated sufficiently long. So you're absolutely right. I do not select the patients according to the baseline SOCAL or ELTS, but rather to how they responded to the TKI and the duration of the treatment and the depth of response.
So in the same line, if we have tried TFR in about 25 patients, and one of the patients had a very late loss of response, like 7 years out. So how long do we continue to monitor PCR? Because patients after some time stop even following, or they get a bit relaxed and they don't come every 3 months.
So the agenda of the monitoring is very important but there are several aspects. It's important for the patient, it's important for the doctor, and it's important for the healthcare system. So we should know what's needed, but not too much. So I must say I'm much more relaxed than what's published. During the learning phase in clinical studies, we used to say monthly, then every 2 months, then every 3 months, lifelong. I stopped doing this. First of all, when you stop in deep molecular response, it's not automatically needed. Of course, if you stop in non-optimal conditions for some toxicity reasons, then you might stick to this schedule. So I do it first every 2 months during the first 6 months. Then if the patient remains in deep molecular response, I do it every 3 months during the first year and the second year. And after the second year, if the patient is still in deep molecular response, I do it every 6 months until the 5th year. And as the very late relapses are very rare, after 5 years, if they are still in DMR, so MR4 or MR4.5, I have too many patients right now and I need to treat the new ones. So I say, come back every year. So, and this works. Now, some people say, yes, but you may jeopardize the patients who may increase in between and so on and so on. But this is a flexible way of, it's not dogmatic. Let's say, if you see that at one point the patient is not in DMR anymore, but in MMR, of course, you can call him and say, now we need one more point between the two, you see. So it's not like being blind and sticking in a dogmatic way to this, but you can adapt depending on the results. So if your results is still DMR, stick to the schedule. But if you see that there's a little bit of increase, tell the patients to come back 3 months later, let's say. So, and this, when it's explained to the patients, they understand very well. And this is a way to, first for the doctors to have room to treat patients who are really in danger, so the other patients. On the other hand, not to give up these TFR patients, and not to lead to too much anxiety with too many tests, but so not too much, but not too little. And third, to make to save money for the healthcare system, because this is also expensive, and then to not to jeopardize the patient on the long term. So I advocate for a more flexible monitoring practice, adapting to the patient situation and not to the learning phase that we did 20 years ago or 15 years ago.
Thank you, ma'am.
Thank you, Dr. Chiraksha. Dr. Upendra Sharma, your question, please.
Thank you, Dr. Delphin, for that excellent talk, enlightening us on the difficult situations in the management of chronic myeloid leukemia. So sometimes we have patients newly diagnosed CML in the first trimester of pregnancy. So a real challenge in those circumstances, how we manage a patient in the first trimester of pregnancy with the newly diagnosed of CML-CP?
So when we have patients, so I think there will be before allosteric inhibitors and after allosteric inhibitors era. But right now, for us, at least in Europe, we're still waiting for the approval of allosteric inhibitors. So I'm going to talk about the classical ATP, non-selective ATP competitive inhibitor. I know that practices vary around the world, depending on the drug price, on the patient, on the health system, and also on the characteristics of the treating physician. But in my center, where we have all TKIs available, we decided that if there is no prohibitive comorbidity, everyone would get a second generation TKI. And then you choose which type of second generation TKI depending on the comorbidities, like better dasaptinib if the patient has diabetes or ischemic disease, better nilotinib if the patient has lung disease or liver disease for bosutinib. So, but in the patients who have a high degree of comorbidity for all TKI, then we used imatinib and change the treatment only if there is a resistance or warning if the patient really wants to reach TFR. Now, I must say that when allosteric inhibitors will be available, we might use it more widely in almost all patients. I don't think that, of course, CML is heterogeneous. So if you think that one drug would treat for all patients, it sounds a little bit strange. But I think that we must, and I don't think that one drug will succeed in all patients, but it's really well tolerated. So I think the goal for the future is to try to figure out who is at high risk at diagnosis, to have a better scoring system, linking the baseline prognostic system and the response dynamics. Because very high-risk patients, they might need dual inhibition, several TKIs at the same time. But for most of the patients, I think that the most efficient and the best tolerated would be the best way to increase the patients who are going to be candidate for TFR.
No, so my question is, so in young patients who are pregnant, so
Yeah.
patient comes to us in the first trimester of pregnancy. And
Sorry, excuse me?
patient comes to us in the first trimester of pregnancy.
Yeah.
Newly diagnosed CML-CP.
Yeah.
First trimester pregnancy. So how we approach those patients? Which TK, whether TK, because we say that TKIs, they are not safe in the first trimester because of the patient.
Yeah. So you're talking about the patient who comes and is diagnosed CML during pregnancy.
Pregnancy, first trimester pregnancy.
Yeah. First line, you mean?
Yeah, newly diagnosed patient.
Newly diagnosed and pregnant.
CML patient. Patient comes with high TLC count in the first trimester, say 8 weeks of pregnancy, high
Okay.
count. Instead diagnosed as CML-CP. So how we manage those patients?
Yeah. So for a patient who comes and is pregnant and is diagnosed CML, it really depends on the stage of the pregnancy, because if she has, first of all, we need to ask the patient. Some patients are going to be afraid, and it's early pregnancy, they may ask for termination, for abortion. So this is really an individual discussion. But I think that we learned a lot all over the years, because 15 years or 10 years ago, we would say no TKI during pregnancy. And in fact, we know that it's not true anymore. So it makes pregnancy easier to manage. I think that as long as the patient is during organogenesis, of course, no TKI, but after the first trimester, we might give a TKI to the patient, except for dasatinib, without jeopardizing outcome. So this makes really the management of pregnancy more easier than what we used to do before. So I would say if she's diagnosed during the first trimester, then I will try to give a little bit of interferon or hydroxyurea or leukophoresis if really the counts are really high. But after the first trimester, you could introduce imatinib without any problem, so that the patient reaches a CHR and has until delivery, and then you could eventually switch to a second G after delivery. So I think that right now, when we know that we can give TKI except for dasatinib after the first trimester, it makes things much more simple than it used to be before.
Thank you. Thank you.
Thank you, sir. Sir, ma'am, from the same note, if the patient is young, diagnosed as CML, not pregnant, but taken dasatinib for 3 years, now in complete remissions in the last 2 years, deep molecular remission in the last 2 years, opted for TFR, or now wants to go for pregnancy, wishes to become pregnant. So when should the dasatinib be stopped?
All right.
Just before the pregnancy, or tomorrow she wants to become pregnant, so should stop now and then ask her to become pregnant after 3 months?
So I guess that depending on the physician, you will get a little bit different answers. So I will tell you how I do. First of all, I could eventually try to dose decrease little by little and to see if she remains in deep molecular response. But since she wants to be pregnant, let's say I don't dose decrease. So we know now that the embryo should not be exposed to TKI during organogenesis, but organogenesis doesn't start immediately. So you have a couple of weeks. So I don't interrupt the TKI before. So I tell after 3 years, you're in good response. It's okay for getting pregnant. I don't stop the TKI before the patient becomes pregnant. I tell her, remain on TKI, but please, each month you do you stop your pills if you have a contraception pill or whatever, and you can be pregnant. But the embryo should not be exposed during organogenesis, so we must know as soon as possible when you are pregnant in order to stop the drug. So I tell the patients either to do a systematic pregnancy test every month, or to do it if she has a delay in the period. And if it's positive, she stops immediately the TKI. So it's before organogenesis. And if the test is negative, she goes on with the TKI, so that we limit the risk that she would lose the response before getting pregnant. And that's now how I do for all of the patients who want a baby.
Great. Thank you, ma'am. Another question is from Dr. From Dr. E. Montent. What is the longest interval and the dose of longest interval for the TKI with TKI when the patient can have cytopenia for the longest period without the blast count in the peripheral blood, increase in the blast count in the peripheral blood or in the bone marrow, according to your experience? So the longest interval of cytopenia you have experienced with TKI.
You mean at the beginning of the treatment?
So once the patient has been introduced TKI, becomes cytopenic, till how long the patient can be cytopenic?
Okay.
After stopping TKI.
Yeah, so of course we're talking about early cytopenia, because late cytopenia, it's a different diagnosis. I must say that if the patient does not fully recover, recover to non-dangerous stage, it could be a little bit cytopenic, but if it's not deep, that's okay if the patient responds. But you will know with it, if there's no recovery between the 3 and 6 months, then you really need to transplant. If it's really still deep cytopenia and empty bone marrow, nothing will happen. Of course, sometimes we have patients who are old, who don't have a donor, So you are not going to transplant, and sometimes we have surprises. I must say that I had a lady like this 3 years ago, and it was not pancytopenia, it was mainly on the platelets. And little by little, she was on dasatinib, nilotinib first, and dasatinib, but dasatinib gives more thrombocytopenia than the others. And finally, we managed on asciminib, which is a little bit less toxic, to and platelet growth factors to normalize the blood count, and she now has a good response, but she was not treated according to the guidelines because she finally managed to get an MMR after 3 years. So before, she used to be classified as resistant, but there was no donor. So sometimes you manage to rescue the patient after 2 and 3 years with less toxic TKIs, with more selective TKI and with growth factors, but you never know. I mean, we don't see the future. I mean, these patients might have transformed before. So this is just because you don't have the choice in these patients. You can't transplant, they don't have a donor. But usually what we do is that when they have a grade 3-4 recurrent cytopenia, we make the decision for transplantation within 6 months.
Thank you, ma'am. Suppose if you stop TKI, patient is cytopenic, you stop TKI. Till how long you will wait for the cytopenia to recover?
So I try to restart. As I said, I'm not using the guidelines of the SMPC since I think they are not adapted to the clinical relevance of the cytopenia. So as long as when neutrophil recur above 500 per millimeter cube, I restart the TKI at a lower dose, well, the full dose at the beginning and then at a lower dose. For platelets, I use a threshold of 20,000 for those who are not on aspirin or anticoagulant drugs. And I maintain the TKI on L-thrombopag, and I just stop if there is a bleeding or if the platelet decrease below 20,000, and then I restart. If I have to interrupt, I restart above at 50,000 per millimeter cube. For anemia, I don't stop the TKI. I just give EPO or transfusion. It works very well. So I use thresholds which are relevant for the clinic and not relevant for the regulation and the what you see in the leaflet of the pharmaceutical company, which are not really corresponding to the physiopathology, especially when you have, for the neutrophils, when you have patients with a peripheral neutropenia, very benign, like in Africa. In the Mediterranean, very often the physiological neutrophils are not 1,000, it's below. It's just excessive margination in the blood. It's not true neutropenia. So if you use this in these patients, you will interrupt all the time and it's not needed.
Thank you, ma'am. Dr. Radhika, your question.
Thank you, ma'am, for the enlightening presentation. My question is TKI safe in lactation? If so, which TKI is safer in lactation, breastfeeding in lactation?
So we know that some of the TKIs can be found in the milk. For some, it's really at very low levels. But I think that my personal view is not to allow lactation if the TKI is absolutely needed for the mother. But I tried, if the molecular response is still stable and okay after delivery, let's say in MR2, MR3 or deeper, then I tried to allow lactation, but without any TKI treatment as long as possible, for at least 3 months if it's possible, 6 if it's possible. So I personally avoid any TKI treatment during lactation because the baby should not be exposed.
So generally in India, the lactation is continued for almost 2 years or even more than that. So yeah. We cannot afford to. You mean to say the lactation should be completely off if the patient is not in molecular response post-delivery?
If the patient is not in good molecular response, then yes, we don't allow the lactation. But I know we have cultural differences and also social society differences between the Western world and India. And I understand that the lactation does last for quite a long time in a lot of women in India, but this is usually not the case in our country. So that is first easier for us to stop the lactation, especially the women. Usually they restart working, so they are not going to give the milk to the baby. The second thing is that we may be sued if the baby has a complication due to TKI in the milk. So for reasons which are non-medical reasons, but more legal reasons, we try to avoid exposure of the baby. But I must say that what you could do if the lady really wants to give the milk and if it's needed for the baby, but for 2 years, which is quite long, most of the patients will not be okay for 2 years without any treatment. You could try to decrease the TKI doses so that there is a very little amount in the milk and so that the baby is safe.
Yeah. So generally what I have been for patients who has been insisting on breastfeeding, what I do is I reduce the dose of imatinib to 200 mg. And I ask them to space the imatinib with the breastfeeding, means almost like 12 hours gap between the dosage and the breastfeeding. Is that like a reasonable strategy?
Yeah, this is a very, very smart strategy.
Sure. Thank you very much, ma'am. Thanks.
Thank you, Dr. Radhika. Dr. Bhuvesh Gauri, your question.
Thank you, ma'am. Thank you, Mitsa. Dr. Ria, is there a situation where we might think about introducing PEG interferon on top of a TKI like imatinib in a patient losing response where they might have comorbidities and will not be able to cycle through different TKIs?
I understand your question, since interferon was the first treatment that allowed responses and prolonged survival before tyrosine kinase inhibitor treatment. The problem is that we have been pretty much disappointed with the trials combination therapy between TKI and interferon, because we never managed to show what was the clinical benefit. We knew that we could have deeper molecular responses, but we were never able to show that we had more TFR or prolonged survival. And we know that we added some toxicities, let's say, especially for the patient. So at least in the French experience in PEG interferon plus TKI trials, we were not able to maintain the combination therapy for more than 1 or 2 years, and the patients were a little bit fed up with the side effects of the combination. So the second thing is that the dynamics of action of interferon is much slower than that of TKI. So if you want a quick response, interferon is not the right drug to use. Of course, this might be an opportunity, but please remember that you have only between 10 and 20% of patients with a partial cytogenetic response or more on interferon alone. So we must say that interferon is still a very useful drug. You see here in the patients with hairy cell, but this is quite a rare situation. But we use it also during pregnancy when we need to stabilize the molecular response or maintain a CHR when the residual disease burden increases quite rapidly soon after the pregnancy. Otherwise, unfortunately, we are a little bit disappointed. We had a lot of hopes on interferon immune action, and right now we don't really know what is the real benefit, at least for except in specific situations. It could work for
Indeed, thank you.
thrombocytosis at the beginning. Maybe we didn't try, for huge thrombocytosis at diagnosis, maybe it could be useful. I don't know. I didn't have the opportunity to try in these cases.
Thank you, Dr.
Thank you.
Gauri. There's a question from Dr. Shyam. He has a 22 years old male CML CP on dasatinib for 5 years. At present, the molecular response is 0.1. Would you do any intervention to get him to TFR? Number 1. And if you continue with dasatinib, when do you think he will actually achieve MR 4.5? And if he achieves MR 4.5, can we try TFR at that time?
So at 0.1, I would not stop the treatment unless there is a high degree of toxicity. Sometimes you have the surprise when we have a high degree of severe toxicity to maintain the treatment, a patient without a treatment to CTFR, but it's very rare. I have patients like this who manage to remain without treatment, but it's pretty rare. So now, would I like to have a deeper response and change the treatment? First, the answer is yes, I would like to have a deeper response. But the problem is that today I don't know what to do. I don't know how to do. I don't know what to do. And I don't know whether a stronger TKI such as ponatinib would do the job, because it has not been tested in such situation. And the second is that I would induce a lot of cardiovascular risk. So the risk and the benefits are not obvious. So today I would maintain him on dasatinib, and tomorrow maybe not. Whether we are going to be able to prove that a different strategy, non-toxic, would get him into a deep response, that I would go immediately for it. But today I don't know what to do for these patients. So usually, unless there is a high degree of toxicity or clinical trial with new drugs, I maintain the treatment. Now, is the patient going to be able to get a deep response if we don't change the treatment? Probably not, but sometimes yes. I know you would not like this answer, but here we know that there are some strange phenomenon after 10 or 15 years, sometimes on TKI treatment. Patients who are in MMR, and at very late stage, you see deep molecular responses, but this is not quite frequent, but this sometimes happen. Maybe after 10 or 20 years of treatment, we exhaust the leukemic stem cells. But usually the patients stay in MR3 or MR4. So, and if you get a late deep response, yes, why not stopping the TKI, of course.
Perfect. Another question is from Dr. Shyam. Young CML CP, what would be your treatment in 2025? Would you prefer second generation TKI? Upfront, number one. Would you go for asciminib? Number two. Or you will go for asciminib plus dasatinib? Number three.
So combination, we don't have, we are not allowed to do it. And so if I would have a trial, I would go for it. But without a trial, I'm not going to do it. I would like to give asciminib, but I must say that I would also like to have in young people and in different risk group, I would like to see analysis comparing asciminib with second generation TKI in the different risk group, low, intermediate, high, and I didn't see any analysis right now. So I cannot say if asciminib overall seems to be better than second G, but for subgroup analysis, I'm missing some data. So I would hesitate still between dasatinib, which is much cheaper, it's a generic drug, and asciminib, which is going to be very expensive. I will talk with the patient and try to decide.
Thank you, ma'am. Dr. Chirag Shah, your question.
Yes, in the similar line on the asciminib, even though the short-term responses are deeper, faster, and the side effect profile seems better, NCCN has not put it as preferred in any of the categories. So it remains one of the options. Is there a reason why it is not considered preferred?
I think that there are the considerations. First of all, I think that we can talk with a patient about different risk and different advantage of different drugs. I think also that it depends on whether the patient has a good health coverage or not. Asciminib is now not is a new drug, so the price are going to be different, and depending on health insurance of the patient, he may have the opportunity to get reimbursement or not. So this is something very important to take into consideration. I told you that I was missing some, if we put the money, the financial issue apart, of course you would like to use asciminib in all situations, but as I said, we are missing subgroup analysis depending on the risk scores. So if we prove that there's a big difference between high-risk patients, then we might have more medical arguments to choose one drug or the others. But currently, we don't have this kind of data. I'm sure that the pharma have. We need to do our own subgroup analysis or to ask a pharma to do a precise subgroup analysis. So I think that's why they didn't really recommend one drug over another.
Thank you.
Thank you, Dr. Chirag Shah. There is a wonderful question from Dr. Christopher Chin. He has an elderly man, initially with pen myelinosis, diagnosed to have a JAK2 positive polycythemia vera and started on hydroxyurea. But the cytogenetics later found that he had translocation 922 also, and the treatment was switched from hydroxyurea to imatinib immediately. He achieves MMR at the end of 3 months, deep molecular response at the end of 6 months. However, the panmyelosis recurred. How to approach such patient?
Well, for CML, you could maybe propose him a treatment-free remission attempt. I mean, and treat the other disease then without association with the TKI. I mean, these are usually independent clones anyway. So usually when you see patients with several myeloid malignancies at the same time or several hematological malignancies at the same time, it's not within the same clone. I think these patients are prone to have hematological diseases, but usually it's not in the same clone. So, I mean, treat the two diseases independently, and if you have a problem with imatinib combination with a other treatment, then you might try to discontinue imatinib and see if the patient can remain drug-free, at least on the CML side.
Thank you, ma'am. Dr. Yimon Tent, you have a question? You can ask your question directly. Dr. Yimon Tent?
Sir, thank you so much. I want to know in cytopenia patients, how longest interval of TKI, yes, dose adjustment and minimum dosage can I use in cytopenia?
This is really patient dependent. I don't think there is a global rule for all patients. I mean, you could, when you interrupt and then restart by dose decreases, just do it step by step, and you could go down to the lowest dose. I mean, it could be down to 100 of imatinib, 20 of DASA, 150 of Nilo, and so on. But this is really individual. I mean, if the patient responds to the low dose drug and doesn't have recurrent cytopenia, then you're fine. It's just that if you dose decrease, you have to dose decrease very low, and then the patient doesn't respond, then try to switch to another tyrosine kinase inhibitor. Or transplant eventually if you can. But so I don't think there is a rule. I think it's really decisions that have to be made based on the individual decision. Lowest dose of TKI, if it does it allow cytopenia to be a little bit less severe, and does it allow a molecular response?
Yeah.
Yes, thank you. Second question is, how will you treat if both JAK2 and BCR-ABL positive MPN patient?
So as indeed this happens, that the patients has polycythemia vera and CML either diagnosed at the same time or separately, or ET. I think that for MF, it's less frequent, but we treat the two diseases. I mean, sometimes if you have PV, I mean, if you have a polycythemia, you can try to use a TKI for CML that induces anemia, so that you don't need so much treatment for the red blood cells. Like imatinib usually induces a little bit of anemia, and but you could also envisage, if you want a molecular response, if it's a JAK2 positive disease, it would be worthwhile to have an effect on the clone. Because it has been shown that when you reduce a JAK2 clone, then you have a much better outcome. So you may envisage, if you have access to that, to combine the TKI with interferon.
Yes, thank you so much, Madam.
Thank you, Dr. Imonten. Another question is, do you perform molecular testing at diagnosis in addition to BCR-ABL testing?
So yes, very important questions, as we know that there are some molecular abnormalities that induce maybe a risk of resistance to TKIs, such as SXL1 mutations, but they are pretty rare. It's not more than 9% of the CML patients at diagnosis. And sometimes some patients respond. So the answer, whether this should be really done in a routine practice, it clearly is not clear at all. So we do, but it's for research purposes. Sorry, we do an NGS analysis panel with 100 genes, myeloid and lymphoid, because it's not an MPN panel. But it's for research purposes. We don't use it as a treatment decision for, to decide which treatment we are going to start. We really use it to try to figure out whether we could have better prognostic factors in CML, integrating these markers and also integrating the early molecular response as a dynamic point of view.
Thank you, ma'am. Dr. Vinayak Chakodi, your question, please. Yes, Dr. Vinayak. You're muted, Dr. Vinayak. Dr. Vinayak, we can't hear you. Yeah, so in the meantime, Dr. Upendra Sharma, your question.
So Dr. Delphin, so a few questions. So whether pegylated interferon is safe in pregnancy?
Sorry, if I use...
Pegylated interferon.
Yeah.
Safe in pregnancy?
Yeah, it's pretty safe in pregnancy. There is no specific, I mean, you know that it's not only used in few CML patients, but it's also used for multiple sclerosis. So there is a wide experience outside the CML field. Of course, in multiple sclerosis, it's interferon beta, but it's more or less the same as alpha for side effect reasons. So there is no specific problem during pregnancy as compared to the non-pregnant women. I use the same precaution. I mean, checking for thyroid function, checking for liver enzymes, making sure that the patient does not have ischemic cardiac disease, but usually it's not the case for young women who are pregnant. So I'm not doing handling the treatment different than in non-pregnant women. Sometimes they might be a little bit more tired than the women who are not pregnant, so I may adapt either the dose or the injection frequency. Very often I don't use more than 90 micrograms per week for pegylated, because above it's really inducing a lot of fatigue. And as soon as I see that the molecular response is stable, I try to inject every 2 weeks or every 4 weeks, depending on the individual situation, and try not to maintain the patients on a weekly injection if it's not necessary, to decrease the fatigue, especially at the late stage of the pregnancy, in which it's a little bit more difficult to handle this kind of treatment.
A male wants to become father, so any recommendations for that?
The TKIs are not genotoxic, so they are not going to induce mutations in the DNA of the spermatozoids. They can sometimes decrease a little bit the amount of the spermatozoids, but usually there is no alert on any infertility. So I just don't do anything. I just say that they can become father. They just have to do it normal way. In case there would be a problem in fertility which would come from them, then we can, since the spermatozoids are made every 3 months, not like in women, we can still interrupt to have a spermatogenesis which is done without a TKI. So, but most of the time I tell the father, just try to build your family like the other. I don't interrupt TKI.
So one last question, Dr. Amit, can I ask?
Yeah, please go ahead.
So I have one patient, 50-year male, newly diagnosed CML. CP started on dasatinib. On 3 months, he had early molecular response, and on 6 months, his BCR-ABL transcript is 0.5. And now patient having a massive cardiac myocardial infarction, so TKI was stopped. So which TKI do you prefer in this patient now?
So 1.5 at 6 months and cardiac dysfunction.
So 0.5% BCR-ABL at 6 months.
Yeah.
And so having a good response, early molecular response at 3 months, and 0.5% BCR-ABL at...
But a cardiac problem, you said, huh?
Yes, so having massive myocardial infarction on dasatinib for 6 months.
Okay,
So which
so
is preferred TKI now?
Yeah, so usually the risk of of cardiovascular disease, of course, it's not, background risk is not zero, and the increased risks have been demonstrated for nilotinib and for ponatinib, but not so much for the other tyrosine kinase inhibitors. So I would not automatically change the treatment. If it's just, I would try to decrease the dose of the TKI, but I would maintain him on dasatinib.
So low dose dasatinib.
Yeah.
Thank you.
Low dose meaning 50 milligram.
It depends on, if it's still on 100, I would do it in a stepwise fashion. So I would first go down to 70, and then if the molecular response is maintained after 6 to 1 year, I would try to go to 50. So it really depends on what dose you have right now, and then I would do it, I mean, because you should not lose the benefit of the treatment. So I do it in a stepwise fashion, making sure that the molecular response is maintained in between.
So
and if the step is good, then I go to the next step.
So patient sometimes we start with low dose dasatinib.
Yeah.
So if patient is in 50 milligram, then you continue, or
if he's on 40 milligram in
50
MMR, then
milligram.
you can try 20, but be careful. Then in that case, I discuss with the patient, and let's say I tell him that I could do more molecular tests. I mean, I just to make sure that I'm not losing anything. I mean, that the efficiency is not lost.
So do you prefer imatinib or asciminib in certain circumstances?
I mean, when a patient is a good responder to a drug, it shouldn't matter. But usually for dose reduction, imatinib, if you go too low, you lose the response. So I would be careful with dose reduction of imatinib treated patients.
we don't know that dasatinib might be the dasatinib was a culprit for this myocardial infarction. We don't know.
Yeah, but most of the time, dasatinib is not increasing the risk of atherosclerotic plaques. So unless you have another reason for myocardial infarction outside cholesterol and plaques, I would not discontinue the TKI. I mean, I think we have pretty good data to say that the risk is not so much higher above the background general population for dasatinib, imatinib, bosutinib, and asciminib, and it's higher for nilotinib and pona. For nilo and pona, definitely I would change the TKI, but not for these ones. I would just try to decrease the dosage.
Thank you.
Thank you, Dr. Upendra Sharma. There's one question from the audience. Dr. Priyanka wants to know if you have a patient who has got atypical CML with ATV6 ABL1 fusion gene on NGS, how would you treat? Number one. And the patient was negative for BCR ABL and for any atypical transcript for BCR ABL. And this mutation was only on NGS. The clinical profile as well as the peripheral blood and the bone marrow picture were matching with CML CP. So how do you approach such patients now?
So if you have a CML-like disease with ETV6 ABL, you could use you can use a TKI that we use against CML, but not an allosteric inhibitor. You have to use an ATP competitive inhibitor because these atypical these CML-like disease are not, usually they are missing some sequences in the exon 2 of ABL, and they are not sensitive to allosteric inhibitors. So I would treat with dasatinib this patient.
Thank you, ma'am. Thanks a lot. Dr. Vinayak Chikodi, your question. Dr. Vinayak? Yeah, Dr. Vinayak Chikodi. You're muted, Dr. Vinayak.
Yes. Is asciminib the best drug to achieve TFR? Hello?
Yeah, so sorry. We don't know. I think, no, I can develop a little bit my answer. What we see from the data from the first line study, for the patients for which today you would choose imatinib for comorbidity reasons or for age reasons, tomorrow you will be able to use asciminib because it's not dangerous for elderly patients and it's not dangerous in case of comorbidity, and you will double the chance to have a deep response and get into TFR. So doubling is really important. So for this patient population, definitively yes. for the patients today for which you would give a second generation TKI, it's not the advantage for TFR is not that clear. There might be a small advantage for tolerability reasons, because if the treatment is very well tolerated, then the exposure to the treatment will be better. So you will probably decrease the risk of decreasing the dose, of interrupting the TKI. So there might be a small gain. We will have to wait for long-term data from ASFOR first and ASFOR START. But for the first patient population in which you would have chosen imatinib, not just because it's the available drug and it's cheap, but because for comorbidity reasons you think it's the best drug, then here tomorrow allosteric will do much, much better, and they will double the TFR rates, yes.
Thank you, madam. Thank you.
Thank you, Dr. Vinayak. One question is there from
Thank you.
Thank you. So one question is from Dr. Priyanka. How long would you wait for a bone marrow examination for a drug-induced cytopenia?
If it's mild, if it's less than grade 2, then I'm not going to do a bone marrow examination. If there is no other atypical symptoms or biological signs. If it's a grade 3, 4, if it's just one episode recurring one time but not more, then I would, but then resolving, I would not do it. Now, if it's grade 3, 4 recurring more than 2 times, then I would definitely do the bone marrow. Usually what we find is empty bone marrow, very little hematopoiesis. But still, it's not because that's what we see usually that we shouldn't do it, because sometimes we might find a blast crisis in pancytopenic form or fibrosis of the bone marrow if you do a bone marrow biopsy. So let's say I do it in case of recurrent grade 3, 4, despite dose reduction, interruption, and growth factors. This helps to decide whether we have to look for a donor or not.
True. And suppose if the patient develops cytopenia and you stop TKI, how long would you wait that the cytopenia should recover? After within 2 weeks, cytopenia should recover. Within 3 weeks, it should recover. So
yeah, it should recover within 2 to 4 weeks. If it doesn't, then there is something wrong going on, and do a bone marrow analysis.
Perfect. Fine. So any other question? Anybody else?
Yeah,
So
I'm Dr. Patra here.
yeah, go ahead.
So, ma'am, nice presentation. I want to know about one patient. He is a 29 years old male, post-renal transplant. So, creatinine maintaining like 1.4 to 1.5. Now he develops CML. So, in this scenario, what will be the choice of TKI here?
What is the disease that led to renal transplantation?
It's unknown actually, probably hypertension.
Okay.
Okay.
So I would avoid, so of course you have to look at the CML risk, because you have to take into account also what is the risk of CML, but he's young, so I would try to use not imatinib for 2 reasons. First, because he's young. Second, because we know that on the long term, imatinib has some renal effect. I would not use bosutinib either. We know that on the long term, we have decrease in creatinine levels with bosutinib, and we also know so I would avoid imatinib and bosutinib. I would rather use either dasatinib. Now, for nilotinib, maybe on the short term it could be okay, but we know that patients with kidney failure, they have a high cardiovascular risk. So I would probably avoid nilotinib for these reasons, although it might not be urgent. It might be used for a couple of years and then switch. So I would probably prefer to go for dasatinib or asciminib if it's available. Be careful that there will be drug-drug interactions with the immunosuppressors. So at the early stages of treatment, you have to dose the immunosuppressor and readapt if necessary, because there will be a strong modification at the beginning.
Yes, ma'am. We have started with dasatinib only. After 1 year of dasatinib, he developed proliferation. And after 1 year of treatment, he responded well, but he developed proliferation.
Okay.
So now what?
So, of course, you can interrupt, wait until resolution, and then restart dasatinib at a lower dose. Sometimes it works, and sometimes the pleural effusion recurs once again. So the alternative, if you have access to allosteric inhibitor, that would be a good idea. Otherwise, try to use the lowest possible dose with dasatinib to try to avoid recurrence.
Okay, ma'am. Thank you very much.
Thank you, Dr. Patra. Dr. Radhika?
Yeah, thank you, ma'am. So my question is, most of the patients who have been introduced on a low dose dasatinib 50 mg, good number of patients on this particular dose reach an MMR between MR3 and MR4, something like 0.1, 0.16, and they remain on that molecular remission for a long period of time. Like it neither progresses nor it reduces. So something between MR3 and MR4. Patient is happy, I'm happy. Is there any indication for me to increase the dose of 50 mg to 70 mg or 100 mg, or should I switch over to an alternative TKI? Or am I happy to continue dasatinib 50 mg, maintaining an MR between MR3 and MR4?
Excellent question. Thank you very much. For several reasons, I now for a couple of long time I start with full dose dasatinib, but then I decrease the dose of, I try to decrease the dose of all TKI. And indeed, I looked at the Indian trial at EHA, excellent presentation of your study comparing high dose and low dose. So we don't know if he's happy on low dose and you're happy on low dose, then personally I remain. I stabilize the situation. I'm not doing anything more. I just don't increase the dose again. For two reasons. First one is that I'm going to increase the risk of side effects. And the second one is that I have no idea whether if we increase the dose again, the residual disease is going to decrease. I am not sure about that. And it's a mystery why in CML the majority of patients are between MR2 and MR3. And it's like if there was a threshold below which some patients cannot go deeper. And we need to understand the biological basis for that. I don't think that it's just dose related, because for some patients it's also occur on full dose TKI. So there must be some clones which are not very sensitive to at this level, and we need to understand what would be the best strategy if we would like to go to TFR. Maybe it could be combination therapy, but we don't know. So today for these patients, unless they want to go for in a study, in a clinical trial, I'm happy, he's happy, everyone's happy. I don't change anything.
So probably by increasing the dose to dasatinib 70 or dasatinib 100, or by changing out to nilotinib, maybe I'll reach a position where I can introduce TFR. Does it?
If you change for another second generation TKI, you will be disappointed. So I would not do that, but you can try. You make your own experience. But switching in MR2 or in MR3 to a different second generation TKI, if there is no BCR-ABL mutation, usually it doesn't change anything with respect to molecular response.
Sure. Thank you, ma'am. Thanks.
Thank you, Dr. Radhika. Well, ma'am, so I think there are no more recent signs. We have bothered you a lot today, and wonderful question answer session we had with you. Learning experience, fantastic learning experience, and beautiful lecture, wonderful presentation. Always good to listen to you. Thank you so much, ma'am. Wonderful learning as always. What a knowledge you have in the field of CML. Thanks a lot, ma'am. And I also thank all our discussants and the audience here to join this today, and meet you next Saturday, Sunday. Thank you.
Thank you for your kindness. Goodbye.